Hello and welcome to our lesson on endocrinology. There's a number of key components that we'll talk about as we talk about diabetic and other hormone or endocrine related emergencies. Let's go ahead and get started on our lesson. Primary topics will include anatomy and physiology of the endocrine system, and then we'll get into some specific disorders and emergency along with the assessment and care needed to treat these specific endocrine disorders. We know that the endocrine system is an important body system. It's closely linked to the nervous system as it controls numerous physiological processes. Unlike that of the nervous system, which exerts its control through nervous impulses, the endocrine system controls the body predominantly through specialized chemical messengers called hormones. These hormones are fundamental structure units of the endocrine system, and they're referred to as endocrine glands. Each endocrine gland produces one or more hormones. As we progress through the lesson, we'll talk about each one of these as an example of the glands of the pancreas. Each of these glands are going to produce one or more individualized specific hormones, and we'll talk about the different components of the types of endocrine glands later on as we continue through this. But the primary component of this lesson will be the focus on the endocrine glands themselves. Now we know these endocrine glands differ from other glands in that they are ductless. Instead of releasing their hormones through ducts to a localized site or tissue, they secrete their hormones directly into capillaries and then therefore into the circulating blood volume, which releases their chemical products through the ducts and then tend to have a pretty impactful localized effect. For example, saliva glands. They're a type of an exocrine gland. The saliva glands are located near the pharynx, and then they secrete digestive enzymes such as amylase into the pharynx when you see something that's tantalizing or tasty and your mouth begins to water. Now, there are a couple other key components that we must talk about when we think about endocrine glands. 4 primary points. Number 1 is in contrast to exocrine glands, those which tend to be localized. Endocrine glands tend to have a more widespread systemic effect. Number 2, the hormones released by the endocrine glands typically act on distant tissues that are further away. They exert a very specific effect on their designated target tissue to be activated. The third component is going to be such hormones like insulin, for example, may have target organs where other hormones only have a few target organs. So, for example, insulin works on all cells where other components of like the pituitary gland, areas in the brain and things of that nature, they have very specific hormones that are utilized for those specific target tissues. And last but not least is through the release of these hormones, the endocrine system plays a very important role in regulating normal body function, regulating normal homeostasis. So again, as we talked about before, we know endocrine glands have a systemic effects. They act on the specific target tissues in a very specific way, and sometimes they have one specific site that they're going to activate, or they may have multiple targets. We know, as we talked about the homeostatic mechanisms, hormones help keep our body in motion or regulate all the different cell processes that keep our body functioning at peak performance. And we know that when there's alterations in that normal homeostatic mechanism, such as disorders, they're going to result from an under or an overproduction of those specific hormones. If we get into some of the more of the anatomy and physiology, you're going to be able to see some key distinct components. There are 8 major glands within the endocrine system, and they are the hypothalamus, the pituitary gland, the thyroid gland, the parathyroid glands, the thymus, the pancreas, the adrenal gland, and the gonads. The pineal gland is also an endocrine gland, but much of its functions are really going to be, they're still not fully understood. It's really unclear specifically what the pineal gland is actually function is. Hopefully science will lead us in that direction as we move forward. In addition to the endocrine glands, many of the body tissues that you'll see have been found to have endocrine functions. So some of the organs you're going to see that are going to play a role as an endocrine organ as well. Those include things like the kidneys, the heart, the placenta for our OB/GYN patients, and then parts of the digestive tract. The big ones that we predominantly think about with hormones that are going to be related to the endocrine system are going to be the heart and the kidneys. And again, these glands, as you can see in the image here, are located throughout the body. Now, if we start to look at each one of the specific components that you're going to deal with here, we're going to start primarily with the hypothalamus. Now, the hypothalamus is located deep within the cerebellum of the brain. The hypothalamic cells act both as nerve cells for electrical conduction for neurons and as gland cells. The hypothalamus is really a junction or a connection between the central nervous system and the endocrine system. It's like a major switching hub between those two primary components, central nervous system and the autonomic nervous system. As neurons, and many of them are hypothalamic cells, receive message from the autonomic nervous system, or ANS, peripheral nerves that, among other functions, detect internal conditions such as blood pressure or blood glucose levels, and then they convey that information to the central nervous system so that the body can react to those changes in homeostasis. Some of the hypothalamic cells respond by producing nerve impulses that travel to cells of the posterior pituitary gland, and other hypothalamic cells respond to gland cells by producing or releasing hormones into the stalk of the tissue that connects the hypothalamus to the anterior pituitary gland. Just remember, predominantly, this is going to serve as a primary junction pattern between those. You're also going to find that the hypothalamus is really going to have it can regulate the release of a lot of different hormones. Because in response to these hormones, or pardon me, these impulses within the autonomic nervous system, the hypothalamus and the other organs of the endocrine system can release these hormones that will really have an impact on homeostasis. Things like growth hormone or growth hormone releasing hormone, growth hormone inhibiting hormone, thyroid releasing hormone, gonadotropin releasing hormone, prolactin releasing hormone, prolactin inhibiting hormone. We'll get into some more of those details a little bit later, but realistically, it's all about how maintaining that normal process of homeostasis. As we dive a little bit deeper, we'll talk into the pituitary gland. The pituitary gland is also referred to as the master gland. It's only about the size of a pea, and it's divided into an anterior, front, and posterior towards the rear sections or lobes. Now, these tissues have different embryonic organs that are going to, I shouldn't say organs, but origins that are going to have an impact on the relationship with the hypothalamus and based on their different functions with the pituitary gland. If we look at the posterior pituitary gland, it responds to nerve impulse from the hypothalamus, whereas the anterior pituitary gland really responds to the hypothalamic hormones that travel down the stalk and then connects to the anterior pituitary gland along with the hypothalamus. I know that can be kind of confusing for you, but realistically, to remember is that the pituitary hormones have a direct impact on the endocrine glands that are throughout the body. It really is going to be based on what functions you're looking at. And we'll get into some more details with those also a little bit later. The posterior pituitary gland, if we're looking just specifically at that function of it, there are two predominant hormones that are going to be released. Antidiuretic hormone, also known as ADH, also known as vasopressin. Some of you may remember, if you've been in the field long enough, vasopressin was one of the first pressor agents that would be utilized to replace the first or second dose of epi in a cardiac arrest back in 2015. Those standards have since changed, but the idea behind the use of antidiuretic hormone, ADH, or vasopressin was to help cause retention of water to help create additional pressure inside the vessels in a cardiac arrest. Fortunately, that data didn't support its use, and therefore you've seen it removed from the 2020 and further on algorithms. The other hormone that you'll see that's going to be there is going to be oxytocin. Oxytocin is going to be predominantly used for uterine contraction and lactation for our breastfeeding mothers and those OBGYN patients. We know that it does have a mild antidiuretic effect, as that we predominantly see issues where there's an early onset of Braxton Hicks or false contractions, which generally is caused by, believe it or not, dehydration. So a fluid bolus in some of those patients can oftentimes prevent those false uterine contractions by filling their tank up. We know that with antidiuretic hormone, we talked about it being vasopressin. A lot of it is going to be there as a component of it. But when I think about antidiuretic hormone, one of the big things that I always think about is diabetes insipidus. Diabetes insipidus is a marked disorder based on large amounts of volume in your urine, lots and lots and lots of pee that's being secreted in a fashion to reduce or to eliminate specific blood glucose levels. And so those are going to be some of the key things that we'll talk about, and those can be pretty darn significant as we get into those. With the posterior pituitary gland, again, the two hormones, we have the antidiuretic hormone. We talked about that. The big one here is you can see that with normal levels of ADH, it causes a release of water. We typically pee out, or our kidneys function out about 1 to 1.5 liters per day. But with diabetes insipidus, we're going to get significantly more than that. We're going to end up with almost 20 liters in a day. And if you can think about how much blood volume and overall water that's in the human body, it's going to dry them out really quick. So diabetes insipidus is a very severe thing that oftentimes we can see with our diabetic-related patients. We also know that diabetes insipidus is often seen in conjunction with severe traumatic brain injuries as well. Now, if we look at the 6 hormones that are secreted by the anterior pituitary gland, you know that these are going to affect really everything. The primary one that we think about is the growth hormone, or GH. GH affects all different types of cells. It really is a pretty interesting component that we look at. You'll see that not in addition to growth hormone, you have these adrenocorticotropic hormone, or ACTH, thyroid stimulating hormone, TSH, follicle stimulating hormone, that's for ovaries and testes, luteinizing hormones, again, ovaries or testes, and then prolactin, PRN, for mammary glands, which stimulates the release and production of breast milk. We'll get into more specific components of how that impacts the reproductive system as we get into our OBGYN lectures and gynecology, but it's important to recognize that growth hormones really do have an impact on all cells throughout the body. Now, if we look at your thyroid gland as one of the primary components that we'll talk about, there's 2 lobes of the thyroid gland. They're located in the neck, anterior, and just below the cartilage of the larynx, with 1 lobe on either side of the midline. The 2 lobes are connected by a small isthmus or band of tissue that crosses the trachea at the level of the cricoid cartilage. The thyroid is really predominant for 3 major hormones. Thyroxine, I can never say all these all correctly, triiodothyronine, I believe that's how you pronounce it, and caltocin. In essence, you're going to see things where it's going to stimulate cell metabolism, that's thyroxine. The triiodothyronine, I can't say that, T3 stimulates cell metabolism, and then caltocin helps lower blood calcium levels. So it's all part of that process of maintaining the normal functions of those different 3 hormones. Now, the parathyroid gland is going to be interesting. It's going to be located within the thyroid gland, and they're very small pea-shaped style glands that are located, again, near the neck, near the thyroid. Predominantly, you're going to see the parathyroid gland produce parathyroid hormones, which is designed to increase blood calcium levels. Typically, each person should have 4 individual glands. Not everybody does. Sometimes people just have parathyroid problems. But again, the predominant component of the parathyroid gland is to regulate that level of calcium in the body. Now, another one we look at is the thymus gland. The thymus is really interesting because it's located in the mediastinum. It's just behind the sternum, but it's one of these tissues that actually shrink as you get older. So if you look at the image located in the slide, you're going to see that the the thymus gland is very large in a newborn, and as you progress in age, it actually begins to shrink, right? So it's larger in children, and it shrinks as you grow into adulthood. Thymosin is one of the components that are released. It promotes the growth and maturing of the T lymphocytes, or the T cells that are responsible for cell-mediated immunity. And we'll talk about that later on when we get into our allergic reaction and immunology. The pancreas. The pancreas is one that we definitely are relatively familiar with. It's located in the upper retroperitoneum behind the stomach and between the duodenum and the spleen. It's composed of both endocrine and exocrine tissue. That's kind of a unique portion of the pancreas. The endocrine tissue is also going to contribute to secreting digestive enzymes for the breakdown of fats and proteins, and that's into a duct that empties into the small intestine. So for example, you can see here it's a combination organ. The exocrine tissue is called acne. It secretes digestive enzymes into the small intestine. We sometimes refer to this as pancreatic juices. In essence, it's the components that are released from the pancreas directly into the duodenum there to help break down those fats and proteins into a usable source of glucose and energy. It is an endocrine tissue because it also secretes hormones. So we know that with an exocrine, they're ductless. It's going to go directly into the area that's effective. But we know that endocrine components are going to be more systemic. So we see the release of insulin and glucagon. Both are necessary for the use and regulation of sugar, right? Insulin is going to bring down our blood glucose levels, and glucagon is going to increase our blood glucose levels, and we look for the balance of that between those two primary hormones. The pancreas is important with that. So when we deal with diabetic-related emergencies, the type of diabetes, the way that the patient's able to manage those with diet or exercise or medications or insulin injections really depends on how well that endocrine tissue of the pancreas is functioning. We'll get more into that in a second. I love this term, the islets of Langerhans. They are really a cool component, but really the islets of Langerhans are the endocrine tissue located within the pancreas. The islets of Langerhans are made up of three primary components of cell types. The primary one that you look at is beta cells. Beta cells are going to be those that are insulin producing. The beta component is going to be about 60% of the cells located in islets are going to help to release that insulin component. You're also going to see glucagon. Those are the alpha cells that are releasing. It's about 25%. That glucagon is going to help raise our blood sugar. And then we have delta somatostatin, which is about 10%. And the delta somatostatin really are there to help make a balance between the glucagon and insulin effects. Insulin brings down your sugar, glucagon has to bring it up, but at some point it has to level out to maintain that homeostasis, and that's where those delta somatostatin 10% cells exist. There are remaining other cells that are in there as well, and that it makes up about 5% of the islets of Langerhans. So let's go into this a little bit deeper. We know alpha cells stimulate the release of glucagon. Glucagon is used to increase blood glucose level. That's why we give a glucagon injection to someone where we can't establish IV access to raise their sugar. We know that glucagon is going to stimulate the breakdown of glycogen. Glycogen is an interesting component, right? So glucagon stimulates the breakdown of glycogen, the complex carbohydrate that is stored, that is a stored form of glucose, into individual glucose molecules that then are released into the blood. That process of stimulating the breakdown of glycogen into a usable form of sugar is called glycogenolysis, or the storage forms of glucose, right? Or realistically, we could just say that glucagon frees up sugar, glycogen, stored within the liver, because that's a predominant location that those stored sugars are kept, is in your liver. Again, it promotes gluconeogenesis. And this is where the body recognizes and says, hey, I'm out of sugar. I need to create some form of glucose because that's what fuels the body, right? We know the brain requires oxygen and glucose to function and have the central nervous system work as it's supposed to. So with gluconeogenesis, you're going to be looking at the breakdown of new forms of sugar. Sugar that's going to be coming from the breakdown of fats and proteins. However, fats and proteins do not really produce adequate glucose without producing a ton of byproducts. We'll talk about that in a second. But again, it's important to recognize glycogenolysis is where the body releases stored forms of glucose, predominantly in the liver. So glucagon has most of its work in the liver. And it does help produce some gluconeogenesis, which is going to be creating new sugars from the breakdowns of fats and proteins. We see a lot of gluconeogenesis in our DKA patients as well. We'll talk about that too. Beta cells. Hormones are insulin. It's the antagonist of glucagon. It decreases blood glucose level. We also call it the helper protein because it helps facilitate diffusion, right? Helps this process of things moving in and out of those cells. It takes the sugar out of the blood and puts it into the cell. We know insulin is the key that opens up the cell to allow the glucose molecule to be able to go in, to allow for the cell to hold out, to perform its normal functions. It does promote the energy storage in the body by increasing the synthesis of glycogen, proteins, and fats. So when you see insulin that's being released, it's going to utilize and consume some of those sugar, but it's also going to store some of those sugar for later. Later on, it's going to be removed by the liver within about 10 to 15 minutes because too much insulin will bring your sugar down. So we're constantly producing new forms of insulin routinely. The delta cells, or those somatostatin cells, they are going to be what inhibit glucagon and they inhibit insulin. In essence, it slows down or retards nutrient absorption from the intestines. The idea behind this is really not fully understood, but the concept is it relates to some type of balance. So it makes that there has to be some sort of opposition to both insulin and glucagon to maintain that fluctuation in homeostasis. So let's start talking about some endocrine-specific disorders because these are not always fully understood, but I definitely want to make sure that we get into those key components because realistically, you're going to see a number of these as we go through. Now, as a preface to this, the most common endocrine emergencies you should expect to treat will involve complications predominantly of diabetes mellitus. Diabetes is a big component of what we're talking about. But we're going to talk about some pathophysiology of diabetes and its complications, including things like diabetic ketoacidosis, hypoglycemia, and some basic discussions on field management. In addition, we'll talk about some endocrine emergencies that involve things like the thyroid and the adrenal glands. The three primary disorders that I want to talk to you about include the pancreas, the thyroid, and the adrenal gland as we discussed. We'll start with the pancreas because those diabetic-related issues are the most common ones. So why do people end up getting diabetes, right? We know that the disease, diabetes mellitus, is marked by inadequate insulin activity in the body. As we talked about earlier, insulin is critical for maintaining those normal blood glucose levels, and glucose is important for all cells to be able to work, but it's especially important for those brain cells. We know that glucose is the only substance that the brain can readily and efficiently use as an energy source. It can't break down any other components but glucose. That's why we see when someone has an altered mental status, it's oftentimes related to hypoglycemia. In addition, insulin inhibits the body to store energy as glycogen and fats and proteins. It enables that component. It allows for the body to be able to store those. We know that with diabetes mellitus, sometimes we'll refer to it as the sugars or sugars diabetes. It's a pretty serious disease process. It affects over 29.1 million Americans. It's about almost 10%, 9.3% of the U.S. population have been diagnosed with diabetes. So you're going to see these emergencies all the time in the field. We have to be able to recognize, though, what are the different types of diabetes that exist. You've probably have heard type 1 or juvenile onset diabetes or type 2, which is an adult onset. Well, let's go into this a little bit further. With type 1, this is a juvenile onset. It means that the majority of the problems that we see are going to be based on a defective pancreas. The pancreas is not secreting its endocrine hormones in the form of insulin. So if it's not releasing insulin, these individuals cannot begin to break down and utilize glucose. And so we find that oftentimes early onset of hyperglycemia or diabetic ketoacidosis is very common with juvenile onset type 1 diabetes. We also know that these individuals are dependent on external sources of insulin in order to control that. Type 1 diabetes is a rather narrow component when you think about the total big picture of those who have diabetes in the United States. The most common one that you're going to see, which accounts for about 90% of the cases, is type 2 onset of diabetes. Now, there's a couple different reasons why this can happen. Number one would be that there's insufficient amounts of insulin that are being produced by the pancreas. So the pancreas is just not efficiently putting out the level of insulin it needs to maintain normal blood glucose. The other component is maybe the pancreas is pushing out lots and lots of insulin, but it's just not effective working good insulin. So it's being produced, but it doesn't really do the job fully, or maybe it only works partially. Those are some examples that you can see. Most of the time with adult onset diabetes, it really has a lot to do with their lifestyle. Are they supersizing and eating lots of sugar and junk and treats all the time? The body is constantly going to be in a state of elevated blood glucose because of that, and it's believed that that overworks the pancreas and may lead to the production of ineffective levels of insulin. So let's take a look at those three components a little bit more. For defective pancreas, it's just not producing insulin at all. It's going to deprive the body of blood sugar molecules because the key, insulin, is not able to unlock the cell for that sugar to get in to work. This is known as type 1 diabetes, which is usually genetic and predominantly affects children. You may see individuals who have type 1 diabetes who have an insulin pump or take insulin injections. There are type 2 diabetics, especially those that are more severe or brittle type 2 diabetics who have constant hyperglycemia, that they may be on a sliding scale of insulin as well too. Problem number 2 is not enough insulin. This is where the pancreas produces insulin, but it's just not enough to meet the numbers of blood sugar molecules that are available. So some of the sugar will get in, but there's not enough of it to get all the sugar that's needed in. Now, some of these sugar molecules will get in, they'll feed some cells, and the rest are just going to collect in the bloodstream, and we would refer to this as type 2 adult onset diabetes. The third factor is where the pancreas produces enough insulin, so we get the amount is out there, but for reasons that are still really unclear, some of the insulin just doesn't unlock the door. It doesn't unlock the cell in order for that glucose molecule to go in. So some get into the cell and others accumulate in the bloodstream. This is another example of type 2 onset diabetes. There is a ton of drugs that affect the pancreas. Most predominantly we see insulin and glucagon. Insulin is again be a substance that reduces blood glucose levels, and glucagon is one that increases blood glucose levels. You're also going to find that you'll have oral hypoglycemics. These stimulate insulin secretion from the pancreas. They make the pancreas create more insulin. Glucotrol, glucophage, metformin, those are probably some of the more common ones that you will see. These are where their body makes the pancreas is producing some, but really just not enough. With hyperglycemic agents in EMS, we've got to recognize that there's two predominant hyperglycemic agents, glucagon and diazoxide, which we really don't use anymore in the field. But either way, they both are going to help increase blood glucose levels. The biggest one that you're going to see used is glucagon. This is given IM when we're unable to establish IV access. It is a preferred route in comparison to establishing an IO to give dextrose. We do have to reconstitute it. So it comes in a component, we have to mix it, and from there we can end up drawing up 1 milligram to administer IM to that individual, both adult and pediatrics. We also have dextrose, D50 or D50W. It's a 50% dextrose solution that's given intravenously. It does have 25 grams of sugar, but more commonly you're going to see now in the field the use of D10 or D10W, which is really a 10% dextrose solutions. Both a D10 in a 250 ml bag contains 25 grams of sugar, the same as what D50 does. The difference is a 50% concentration, 25 grams of sugar in 50 milliliters versus 25 grams of sugar in 250 milliliters. The difference is how quickly we can spike their sugar when we administer that. The higher the concentration, such as D50, we're going to get a rapid spike in blood sugar, which means we may see a rapid drop in sugar as the body consumes it. But with D10, we're still getting that rise of sugar, still giving 25 grams of sugar, but it's a much slower and controlled rate of the increase in blood glucose levels. And we know with diabetics, we've got to watch that rapid rise and fall because it's very rough and difficult on the individual's body. You'll also see things like D25, D12.5, and then D10, all for children. We'll talk more about that as we get in our pediatric lectures. We know that sugar is a very big molecule, so we oftentimes find when fluids in the body see a large molecule, what are they going to want to do with it? They're going to want to push a lot of water to be able to make sure that it can get to where it needs to. When there's fluids are going to shift into an area where there's high concentration of particulates or particles. So in this case, you're going to oftentimes see with folks who have high blood sugar that they're going to be constantly bringing in liquid to try to dilute that high level of sugar. Remember that the solution to pollution is dilution. That's the same route that we take to lower blood glucose levels as a pre-hospital care provider, but also as a human body would for normal homeostasis. With glucose metabolism, we talked about this already a little bit. Those hormones, both insulin and glucagon, are going to be released, and we talked about how those are going to have an impact. Glucagon's one that's going to be a little bit more complicated because it does have to go through two different processes. Glycogenolysis, which is where the liver goes through this process of breaking down stored components of glucose to produce glucose. And then we also see the liver producing gluconeogenesis, which is finding new sources of sugar from the breakdown of fats, proteins to produce glucose. Now, with metabolism components of glucose, we're going to see a buildup and a breakdown. This is the process of balancing kind of that yin and yang of high and low blood sugar. We know insulin is going to be required for glucose metabolisms, right? We know that there's two predominant things that are necessary for glucose to be there. The building up of glucose in the of metabolism is referred to as anabolism, and the breaking down is referred to as catabolism. And then those two major components that we see for insulin effectiveness is there enough insulin present, and is the insulin working in its appropriate manner? Is there enough ability to bind to the cell to stimulate it to function and allow for that glucose to come in? And when it's unable to obtain energy from glucose, the body really begins to have to go to another source of fuel. It breaks down fats and proteins. This is where we start to see our diabetic ketoacidosis patients. When the body begins to break down new forms of glucose, gluconeogenesis, it's breaking down fats and proteins. Just like, for example, if you were to take in your lawnmower and you were to take and put in a 2-cycle mix of gasoline and oil, it's going to really run rough. It's going to put out a lot of smoke, it's a lot of byproducts compared to if you just put in normal gasoline as it's designed to take. Will it run? Yes, it will run with a gas mixture oil, but it won't run well, and it produces a lot of exhaust and heavy, dark smoke. What does it have to do with diabetes? Same thing happens when you're trying to break down alternative sources of fats and proteins to make a source of glucose. Yes, you'll get glucose out of it, so the body will be able to produce some energy, but we get a lot of breakdowns and byproducts, including things like lactic acid and ketones. All of those are going to create a state where a lower blood pH leading to acidosis or a metabolic problem can exist. Now, when the body breaks down these fats and proteins, it's going to produce ketones as a byproduct, or the exhaust, if you will, of this alternative source of fuel. Those ketones in that process of producing ketones is referred to as ketosis, and it's what we oftentimes will notice in our DKA patients or diabetic ketoacidosis patients, where we can smell that fruity odor like a cheap Boone's Farm wine or some type of fingernail polish like remover on their breath. Those are the ketones that are being released from that process of breaking down fats and proteins. How do we manage these with prescription drugs? Well, predominantly for type 2 diabetes, you're going to see oral medications, right? Now, these two types make sure the person has enough insulin in their system. You have sulfonylureas, which are going to stimulate the pancreas to produce more insulin and encourage those muscles in the liver to use more sugar, right? So it's going to want to be able to create it and to be able to store it. Our other example that we see, Starlex, some of those more common ones that you can see as well too, they stimulate the pancreas to make more insulin. It's probably more common that you'll see sonophorias because you're talking about your glipizide, your glucotrol, any of those metformin, those are all going to be some of the major components that you'll see for that example. We also are going to see a number of other different types of drugs that you'll see, metformin and glucophage, as I mentioned before. These are going to make the cells more receptive to insulin, so when the pancreas is producing some that's not really working well, metformin and glucophage will help make it so that it's more effective. You'll often sometimes find that folks that are largely obese are going to be prescribed these as well to help maintain that glucose production in the liver. Other components that you're going to look at is the alpha glucosinase inhibitors. These are blocking enzymes that help you slow the digestion of blood glucose that happens after you eat. Again, you oftentimes will see that in controlling those who have high levels of blood sugar from type 2 diabetes. All right, so insulin, yes, is it a drug? It's a hormone, but it's also not a drug. But you're going to see it be administered like a drug. Here's an example of a current insulin pump that you can see on the left. On the right is the first insulin pump. You can see how far we have come when it comes to home insulin or slow administration of insulin over a period of time. And another thing with those new meter readers that they have with your smartphone or device, you can monitor your blood glucose levels. All that technology is making the management much easier for patients at home. But you can see how much further we have come. So when we think about the regulation of blood glucose, a normal blood glucose level, which would be done based on a fasting component, so typically they have you stop eating 12 to 24 hours before, and it's a blood test that normally would fall where your blood sugar should be somewhere between 80 to 90 milligrams per deciliter in the blood. Yes, we use 60 as a predominant cutoff, 60 milligrams per deciliter for glucose. If it's lower than 60, we treat it. If it's higher than 60, we kind of typically monitor and observe. But it's what is determined for hypo and hyperglycemia. We know that the pancreas, liver, and the kidneys all have a major component with this. They're there to help filter waste. We know that glucose is important, so when it's filtered, it's pulled out. and then reabsorb so that it can be reutilized again later on. The max about that is about 180 milligrams per deciliter. The rest of it is actually pushed out through the urine. And then we see that through osmotic diuresis and the loss of glucose throughout the urine. That's one of the common reasons why we see with hyperglycemic patients, they have to pee all the time. Or even an example of diabetes insipidus, where the body's going to use that as a way to try to get rid of some of that excessive glucose. With type 1 diabetes mellitus, you often refer to it as insulin-dependent diabetes mellitus. It's an older term now, but it's still utilized. It's characterized by the low production of insulin, and it is hereditary. It results in the pronounced hyperglycemia. These folks' sugars are going to rise. You're going to see things like include weight loss, weakness, and the polyuria, polydyspnea, polyphagia, increased production in urine, and thirst, and hunger. If it's left untreated, it really can lead to ketosis and diabetic ketoacidosis, right? The process of ketosis is where that sugar is not being utilized because there's not enough insulin. So the body breaks down other forms of fats and proteins to produce glucose, produces ketones and acids, and that's what leads to diabetic ketoacidosis. Most of the time for these folks, we're going to want to get their sugar down. So your treatment's going to focus predominantly on IV O2 monitor, pulse oximetry, the use of your capnometry, and then making sure that we're providing adequate fluid boluses to this individual to help bring down their sugar. Remember that the solution to pollution is a dilution. Those are going to be some of the biggest major components that we're going to see. Type 2 diabetes, this is the second requirement for proper insulin activity, as it is binding so that the adequate stimulation of the cells actually occur. You're going to find this is also referred to as non-insulin dependent diabetes mellitus or adult onset diabetes. Again, it results from decreased binding of insulin to the cells. We know that there's some components of it that are considered to be heredity. It's also very largely impacted by obesity, and it accounts for 90% of all the diagnosed diabetes patients in the United States. It's less risk of fat-based metabolism because they're constantly bringing in glucose. So the body's not looking for new sources of glucose. There's plenty of sugar to go around. That's part of the problem. But because of that constant state of high blood glucose level, it results in less pronounced hyperglycemia. So we see hyperglycemic, hyperosmolar, non-ketonic acidosis, also referred to as HHS. Now, HHS is a pretty unique component because basically it's like DKA, but we're not breaking down fats and proteins, so we're not getting the production of ketones or acids. So the sugar is very high, but they don't present with the similar ketones being released like you would see with DKA. So the changes in respiration, the Kussmaul's is not there, the fruity odor on their breath is not there, but everything else remains relatively the same. Predominantly in the field, it's impossible for us to tell if it's HHS or DKA, but it's important to recognize that oftentimes just because your sugar is high does not mean you're automatically progressing into diabetic ketoacidosis. Well, that takes us right into DKA. It results from the body's change to fat metabolism, where it's breaking down fats and proteins for gluconeogenesis as that alternative source of glucose. Because of that, breaking down of those fats and proteins, you're going to get the buildup of ketones, which really adds a lot of acidosis into the system, lowers blood pH, and creates a metabolic acidosis. How does it present? Well, the signs and symptoms you're typically going to see where it's going to be extended period of onset. It's a slower onset to build up, typically 12 to 24 hours. They have that sweet, fruity, odory breath of acetone or cheap wine. You're going to see that you may even have some cardiac-related disturbances because of high levels of potassium. You're going to see Kussmaul's respirations. Those are those fast, deep respirations as they try to blow off that ketones, along with any excess CO2 to help bring down their overall levels of acidosis and raise their pH. And eventually, it will lead to a decline in mental status and a coma if left untreated, up to and including death. Most of your assessment and management is going to focus on your history and your physical exam. Sample and OPQRST is important. Look for that time frame. It's a slower progression as it gets up to that component. And then look for medical alert identifications. Or do they have a history of diabetes, poor diet, any underlying illnesses? If they've been septic. Any of those may be important factors as we're trying to figure out the underlying cause of DKA. And then the field management is predominantly supportive. It's going to be managing those airway, breathing circulation, administering oxygen to the patient if they're hypoxic, avoiding hyperoxia, monitoring pulse oximetry and capnography, your EKG, and then paying close attention to your mental status. We also are going to want to pay attention to minute volume, including things like rate and tidal volume, because that'll oftentimes give us a good understanding if we're dealing with DKA or an example of HHS. And remember, the solution to pollution is, that's right, dilution. Make sure that we're giving them lots of fluid. 20 mLs per kilogram fluid will help eliminate some of that sugar from their system. So again, we talked about this, maintaining an airway and breathing. Make sure that we're checking a blood glucose level on any of our patients with metabolic disorders or altered mental status disorders. It's very easy to check. If you can't get a blood glucose level for some reason, and really today's times we shouldn't have that happen, but let's say that your glucometer explodes when you go to use it, it's better to give sugar to someone if they're even in a high state of sugar than it is to withhold sugar if they were into a low state. You can die very quickly from hypoglycemia. It takes a lot longer to die from hyperglycemia, even DKA. Establish your IV and administer normal saline per your local protocols at 20 mLs per kilogram. Monitor your SpO2. Treat with oxygen if they're hypoxic, but avoid hyperoxia. Use your end tidal to help determine the levels of acidosis that are there, and then make sure that we get this individual to someplace that can provide medications or insulin in this case to help bring down their blood glucose levels as appropriate. Now here's that HHNKS or HHNC, or now referred to as in your current textbooks as HHS. The biggest thing that you're going to be looking at here is we know that with HHS, it's found predominantly in those who have type 2 diabetes. This is again referred to as hyperosmolar hyperglycemic state. The thing about this is a very serious complication with those who suffer from type 2 diabetes. Typically, you're going to find both insulin and glucagon activity are going to be present. So you're going to have some glucose, you're going to have some insulin production, but it's really not going to work out very well. The difference here is that they end up having a sustained hyperglycemic effect for a very long time. Their glucose levels can get up to 1,000 milligrams per deciliter. Most of your mobile glucometers you have will go as high as maybe 500 to 600, but and then read just HI or high after that. But these guys can definitely get a lot higher than even your DKA patients. Now, why? Well, it has to do with the fact that the body's insulin is working kinda. Some of it's being effective. So what is it doing? Well, it's preventing the breakdown of fats and proteins as an alternative source of new glucose, right? Gluconeogenesis. It's predominantly utilizing what glucose is being taken in by the body and only able to do so much with it because only so much of that insulin is working. So their sugar levels get very high, but they never move into that breakdown of fats and proteins to go through that process of ketosis to produce ketones. Now, what happens with these guys? Well, we oftentimes see that sustained hyperglycemia leads to osmotic diuresis, which can lead to some significantly marked dehydration, and water intake is inadequate from the individual taking enough water in to replace the fluids that are lost. You can even see things like dialysis or high osmolarity feeding supplements. This can be caused by an infection and other certain drugs that can all be associated with this onset of HHS. But a lot of the characteristics are going to be similar to that of DKA, minus your Kussmaul's respirations and minus the production of ketones because we're having some effective insulin. That's the key behind this. Dilantin is another common one that you can see, or hydrochlorothiazide is another common one that you may see as well too. The key difference here is that this can go for a long time unrecognized and has a very high mortality rate, more so than that of DKA. So how do we see this? Well, we know DKA has a slower onset, but not nearly as slow as what you have with HHS. It's a gradual onset that takes a couple days, right, in order for it to get there versus 12 to 24 hours like you would see with DKA. We also see an increase in urination, thirst, osmotic hypotension. So if they go to stand up, they may get dizzy or pass out. And then an altered mental status as well. This can be tricky because kind of oftentimes we think it may be in the field DKA because we can't really tell the difference between the two. So what is your assessment? Well, it's impossible really for you to tell if it's DKA or HHS, so you treat it relatively the same. We want to make sure that we're focusing predominantly on that fluid resuscitation to help eliminate any of those major components that are going to be leading to that state of high hyperglycemia. And so we want to make sure that we treat them as appropriately, right? Give the solution to dilution is fluids, right? So the solution to pollution is dilution. You gotta get that right. But either way, you're going to see IVO2 monitor, pulse oximetry, oxygen administration based on if the patient's hypoxic. We want to avoid hyperoxia. Again, make sure you're using your end-tidal CO2 monitoring, and then again, taking them to an appropriate facility. Hypoglycemia. Okay, this is one that's relatively simple. Hypoglycemia, also known as let's wake you up with some sugar, right? It's one of the neatest things that you can do. It's one of the most impactful, immediate reversals of an underlying issue that we can correct in the pre-hospital setting. It is a true medical emergency that results from low blood glucose levels, and it's rarely seen outside of those that are diabetics. Now consider anyone though, for example, maybe they're fasting or maybe they're trying some new type of diet. They haven't had an adequate intake of glucose and they've been expelling a lot of energy. That may lead to a specific problem with their metabolic needs and lead to hypoglycemia. So it can happen to other people, but really it's more of a state of being. It's a state of being without adequate sugars. By the time the signs and symptoms develop, most of the stores of sugar, typically from the liver, have already been consumed. And we know that with children and pediatrics, their liver does not have a large store of glucose. So that window can oftentimes be even slower, especially with the onset of type 1 insulin-dependent or juvenile onset diabetes. We also know that those that are diabetics are often going to have problems with kidney failure, and those folks are going to be more predisposed to having hypoglycemia. Why? Well, if the kidneys aren't working effectively, remember one of the major functions is to reabsorb that sugar so we can maintain it. When the kidneys are having a problem, oftentimes that reabsorption process of that sugar fails to execute properly, and we end up losing more sugar than we retain, leading to hypoglycemia. Signs and symptoms, most of those are going to be based on your altered mental status, right? They can be combative, they can be completely unconscious, or they can be even slightly confused, or really anywhere in between. Some of the other symptoms that you may see or signs would be diaphoresis and tachycardia. You may see even severe progression of where someone suffers from a hypoglycemic seizure or a coma, right? We know that anyone that has a seizure automatically should get a blood glucose check. Anyone with an altered mental status should get a blood glucose check. Anyone with a history of diabetes should get a blood glucose check. And if you're not sure, check their sugar anyways, because it's just too easy to confirm or rule out as a potential for a differential diagnosis. Most of your assessments are going to be focused on the physical exam, sample history, OPQ-RST, medical alert tags, and then recognizing and assessing their blood glucose. Again, we want to make sure our patients have an airway. We support breathing, paying attention to minute volume. We want to make sure that we're properly managing the airway and securing it as necessary. Remember, if their sugar is low, we're not going to want to place a tube in them and then bring their sugar back up. We want to consider basic maneuvers, head tilt chin lifts, rolling them on their side, and then controlling their airway and breathing in that fashion, and then bringing their sugar back up. Obviously, we need to get a blood glucose level to be able to determine the actual reading. And then at that point, establish an IV access if possible and give those 25 grams of sugar, either D50, 25 grams in 50 mLs, or D10, 25 grams in 250 mLs of fluid. Either way is going to be an appropriate way of getting those patients' sugars up. However, once it's up, we need to keep it up. So it's important that that individual receives some type of high protein, complex carbohydrate meal. Peanut butter and toast, lots of protein, lots of carbohydrates. Maybe it's going to be some eggs and toast. You may have to actually take time to make your patient a sandwich. Otherwise, that sugar is going to burn off extremely quickly, and you may be coming right back for that patient in another hypoglycemic state, and it may be even more difficult to get their sugar to elevate. Continuously monitor them. If you cannot establish an IV to get their sugar up, go ahead and do that 0.5 to 1 milligram of glucagon IM. You'll see the local protocols refer to 1 milligram of glucagon IM after we were unable to establish a peripheral IV and administer dextrose. And then depending on the patient's status, we're going to want to go ahead and transport them if they remain unresponsive or remain in a state of unconsciousness. And if they become coherent and they're alert and oriented person, place, time, and event, able to make good informed decisions for themselves, we can consider the use of a refusal and then having them follow up with their primary care physician. So we wake them up and they're fine. They don't want to go to the ER. Now what? Well, as I said before, make sure we're getting our history, paying attention to make sure that our patient is alert and oriented, that they are considered competent, and that recognize that when you administer dextrose D50, that 25 grams of 50 mLs, it only goes for about 15 minutes. So if we leave them home alone, we've got to make sure that they're going to be able to eat. I don't leave a diabetic after I bring their sugar up home alone without me making sure that they've had some food in their belly, even if I've had to make it for them. If we're not able to do that, there's not food in the house, then we may need to go ahead and transport them to the hospital. And then document, right? We got to have something to keep their sugar up, to make sure that we document that, right? So remember, peanut butter and jelly is a great way of doing that. Eggs and toast is a great way of doing that. But stay away from simple sugars, things like soda pop, right? A Coke is not a good way to keep their sugar up. They need something that's going to be more long-term to help stabilize that glucose level. We need to make sure that there's someone there to monitor the patient, or there's someone that's going to be able to be responsible for them, even if it's a patient themselves. And then don't be afraid to contact Med Control if you've got questions. And then follow your local procedures for getting an AMA. And then remember, document it. You can see that all the different signs of symptoms based on a diabetic emergency, whether it's DKA, HHS, or hypoglycemia. There are a lot of similarities between the three, but there are some core things that are going to be different. Remember to pay close attention to that table in your textbook. Now, some other diabetic-related issues you see in pregnancy, we see issues with an onset of pregnancy-related hyperglycemia or diabetes. We can see diabetes insipidus, which we talked about. And we know all of these are going to be results in lower than normal blood glucose levels. They can be controlled by diet regulation, and typically they're going to resolve after the pregnancy is over. Once you've had it once, you're more prone to it the second time, but we'll spend more time talking about diabetes and pregnancy a little bit later. All right, let's talk about your adrenal glands. The adrenal medulla is the inner segment of the adrenal gland. It secretes catecholamine hormones of epi or adrenaline and norepinephrine. We talked about those when we dealt with the sympathetic nervous system and parasympathetic nervous system. Again, as I said before, it's very closely tied to that autonomic nervous system because the cells behave both as nerve cells and, remember, as gland cells as well. Now, your adrenal cortex, the outer layers of the endocrine tissue are going to be what secrete steroidal hormones. These are glucocorticoids, cortisol, aldosterone, estrogen, progesterone, testosterone, angiogenic hormones, a number of major components that are all going to have impact on the body's normal function in the use of those hormones. When we refer to gonads, we're talking for females, ovaries, that's predominant hormones are estrogen and progesterone. That's what controls that normal menstrual cycle. And then for males, it's testes and their control of testosterone. Now, the pineal gland is located at the roof of the thalamus that regulates the clock, the biological clock of the body. It's helping us to relate to reproductive function. It releases the hormone melatonin. It's what helps you be able to sleep and to be able to rest at night. And it also is impacted when we deal with seasonal affective disorder or SAD. A lot of times, especially with the lack of vitamin D or lack of sunshine, it's very common that the pineal gland will produce ineffective levels in the body to help maintain normal, happy levels of dopamine. Other organs with endocrine activity, the placenta, we talk about this a little bit later on as well too in our OBU lecture, but it stimulates progesterone and the release of the pregnancy start. We also have gastrin and secretin, which are going to be released into the digestive tract, and then ANP. ANP is going to be an antagonist to antidiuretic hormone. It reduces circulating blood volume, so ANP actually tells the kidneys start to dump water. So ANP and BNP indicates that there's an overstretching of the heart, right? Starling's law, and it says to the body we probably should get rid of some of those excessive levels of sugar or fluid. Kidneys, for the renin component, the renin-aldosterone system, it helps control that blood pressure. It's going to decrease blood volume. It's going to work with angiotensin, and it's a potent vasoconstrictor, so it's going to help increase blood pressure when needed. And then erythropoietin, which is going to be stimulating the production of red blood cells. We know that with erythropoietin, the kidneys are going to sense hypoxia, typically because of the fact that they're anemic. And it says, hey, you know what? We need to make more erythropoietin, so let's produce some more of those red blood cells. Erythropoietin acts on the E cells within the bone marrow, and then again produces new red blood cells. Those new red blood cells are then picked up and sensed by the kidneys, showing that there's an increase in tissue oxygenation, and then eventually the kidneys decrease erythropoietin production. When there's not enough production, we get back into that state of anemia or hypoxia, and the body continues to recreate this red blood cells through this process of erythropoiesis. This is the renin-angiotensin-aldosterone system. This is excessively complicated. We'll spend more time in class breaking this down. But long story short, it's all about how the body maintains blood pressure, right? We know that we have angiotensin, which then converts into angiotensin 1. Angiotensin is impacted by renin, and that has to do with the decrease in renal perfusion. When we see an increase in renin, we get the production of angiotensin 1. That can be impacted by ACE, which is going to be the surface of the pulmonary and renal endothelium. That leads to the production of angiotensin 2, which does a number of different components. It increases sympathetic activity. We see tubular reabsorption of both sodium and calcium and potassium excretion, along with retaining water. That helps with increasing our blood glucose level. We also see the angiotensin 2 will lead to vasoconstriction, in essence, causing the arterioles to be able to constrict down and increase our blood pressure. And we also see that the posterior pituitary gland, we get the release of antidiuretic hormone, which also begins to hold on to that water as well to raise your blood pressure. Angiotensin 2 will eventually have the release of aldosterone secretion, which is going to have a major impact on controlling the body. And as far as that balance of how much volume is available and how high or low your blood pressure is based on fluid intake. You're going to find that there's a lot of components that go into this, but really if I had to break it down, remember this: water and salt are important, right? Where water goes, salt will follow. Or where salt goes, water will follow. So when the body and the kidneys are saying dump water, where water goes, salt will follow. Where salt goes, other chemical makeups will go as well too. Sugar, other components will get lost as well too. So if I need to push out fluid, I can do that by increasing the release of sodium and calcium. If I need to build the blood pressure, I'm going to tell the body hold on to salt, hold on to that aspect of it so I can continue to build up my circulating blood volume. This can be very complicated. I would definitely encourage you to jump on Khan Academy. There's some really awesome videos that'll explain that process pretty quickly, and at least in simple terms. Graves' disease. Most of the time with Graves' disease, these are pretty rare, but I will tell you, registry does like to ask you a lot of questions about them. The pathophysiology for Graves, it's mostly hereditary in nature. It's in autoantibodies that are generated that stimulate thyroid tissue to produce excessive hormones. We end up with excessive amounts of hormones. How does it present? Agitation, emotional instability, insomnia, poor heat tolerance, weight loss, weakness, dyspnea. We'll see tachycardia with a new onset of issues like AFib, and the protrusion of the eyeballs, where they get these eyeballs that pop out, or we get large goiters in their neck. All those are an example of Graves' disease. Here you can see what those look like, where we get the protrusion of those eyeballs. Most of your assessment and management is really going to be based on cardiovascular-related issues that develop, including the onset of things like AFib. We may have to use beta-adrenergic blockers such as propranolol or other cardiac blockers to help reduce any temporary cardiac stress. And we may also need to consider glucocorticoid therapy as sometimes helpful for reducing those circulating T4 levels, right? Helping control some of those aspects. And then manage the signs and symptoms as they present. You may run into a problem where you have what's called a thyroid toxic crisis, also referred to as a thyroid storm. This is a very life-threatening emergency. It's usually associated with severe physiological stress or overdose on their thyroid hormone. You're going to see things like in a thyroid storm with a fever very high, 106 or higher. We're talking very high. We're going to see reflected to increase activities of the sympathetic nervous system, so irritability, delirium, coma, tachycardia, hypotension, vomiting, diarrhea. And then your assessment and management really focuses on supportive care. Maintain an airway, maintain breathing, and then make sure that we closely monitor our patient and expedite transport. Now with hypothyroidism, on the other end of the spectrum, also referred as myasthenia, it's oftentimes can be inherited or it can be acquired just normally throughout life. Chronically untreated hypothyroidism creates myasthenia. We see thickening of the connective tissues, the skin, and the other tissues like the heart, which can lead to an onset of even like a cardiac tamponade. Infections, trauma, central nervous system depressions, or a cold environment can really trigger the progression into myasthenia coma, which truly would be a major issue. How does it present? You see it present with fatigue, slowed mental function, cold intolerance, it's a big one, constipation, they're going to be lethargic, they're not going to have much emotion, they've got very thin hair, you see a larger tongue, and they get a weird, cool, dough-like skin. And then eventually they can lead to where they'll be in a coma, maybe they're going to have hypothermia and even bradycardia. Most of your focuses with patients who are suffering from myasthenia coma require innovation. You gotta get a tube when you're dealing with myasthenia coma patients. That's very important. You have to maintain that airway. You have to closely monitor their pulmonary status and their cardiac status because of that. Get IV access, but be very careful not to give too much fluid in a myasthenia coma. And then make sure you take them as an expedite transport to an appropriate facility. We know that in these cases, oftentimes can be fatal once respiratory depression occurs. So we have to be excessively aggressive with myasthenia comas and getting in that airway, or a patient can easily lead to a set of respiratory depression or apnea. Hyperadrenalism, also known as Cushing's, you can see where it's adrenal insufficiency and Addison disease. You'll spend more time on these in class. For hyperadrenalisms or Cushing's, you're going to see this due to abnormalities in the anterior pituitary or adrenal cortex. It's going to have a lot to do with steroid therapy. For non-endocrine issues like COPD or asthma can easily lead to Cushing's-like syndrome. Because these folks are on chronic steroids routinely, we see a lot of different changes. Atherosclerosis, diabetes, hypertension, increased response to the body's release of catecholamines, and then things like hypokalemia, low blood potassium levels, and very much more susceptible to that of infection. For Cushing's, you're going to see weight gain. You're going to see a very moon-shaped face, very rounded face in appearance. They oftentimes will get this buffalo fat pad on the back of their neck. They'll have mood swings. They're going to have impaired memory, impaired concentration, but you should be able to tell that there's some type of history that's associated with it. Monitor their airway, support breathing, adequate circulation, monitoring your patient's pulse oximetry, oxygen if they're hypoxic, avoid hyperoxia. Remember to monitor your capnography and EKG component as well too. Be careful when establishing an IV because we can introduce pathogens that makes it very difficult for them to overcome. Remember, they're more susceptible to becoming septic. And then we want to make sure anything that we believe is related to Cushing's that the receiving facility is well aware of early on. Now, for adrenal insufficiency, we have Addison's disease. The pathophysiology of this really has to do with the breakdown and the destruction of the adrenal cortex. It's going to be related again to heredity, and you're going to see stress oftentimes will trigger an Addison's crisis. Most of these are going to again be related to the steroid therapy. For example, maybe they've been taken off of it and they get a sudden withdrawal. Well, that can establish an Addison's-like crisis. Most of your signs and symptoms are going to be progressive weakness, fatigue, decreased appetite, and weight loss. You're also going to see things like hyperpigmentation of the skin and the mucosal membranes. You'll see GI-related problems like vomiting and diarrhea. Hypokalemia is another big one, and other electrolyte disturbances as they lose that potassium. And then adrenal Addison's disease or insufficient adrenal components are going to lead to unexpected cardiovascular collapse or cardiac arrest right out of the blue. Most of your assessment management is going to focus in on, as we've talked, most of these adrenal-like insufficiency diseases. Maintain your ABCs, closely monitor the cardiac and pulmonary status, get a blood glucose level on these patients and treat them if they're hypoglycemic. Be aggressive with fluid therapy and resuscitation and transport these folks by ambulance as quick as possible to the hospital. So in summary, we really have gone through a lot of core information in our hour-long lesson. We've talked about the anatomy and the physiology of both endocrine and exocrine systems, the glands within the bodies, how they control normal homeostatic functions, and then the number of different types of endocrine-related disorders and emergencies, along with their preferred treatments and managements. I hope you had got something out of this lesson, and we'll catch you guys here on the next one.